In the last video, we reviewed the indications and contraindications for lumbar puncture in the ICU. In this video, we will review the method of performing a lumbar puncture. To safely perform a lumbar puncture, the following equipment is required: sterile gown, gloves, face mask and eye protection, sterile drapes, skin preparation solutions such as 2% chlorhexidine and alcohol, a local anaesthetic such as lignocaine, needles and syringes for local anaesthetic application, a spinal needle with or without an introducer needle, a pressure manometer, sample tubes for the collection of CSF, and a dressing for the end of the procedure. The size of the needle is directly related to the incidence of postdural puncture headache. Whilst 22 to 27 gauge needles are ideal for spinal anaesthesia, the viscosity of infected or bloody CSF requires an 18 to 21 gauge needle for diagnostic purposes in CSF sampling. The majority of ICU patients must be placed in a lateral recumbent position. Prior to skin preparation and draping, identification of Tuffler's line between the posterior iliac crests is required. This line intersects L4-5 process or the L4-5 space and can be marked with an ink pen prior to skin cleansing. The spinal cord ends at L1-2 in 75% of adults and lower than L2-3 in less than 1%. For infants, the cord ends at L3. A lumbar puncture is a sterile technique and all sterile precautions should be adhered to. After skin preparation and adequate draping, the landmarks are confirmed. Local anaesthetic can be introduced and should include the skin and ligamentous structures. An introducer needle is sometimes used to facilitate the passage of the smaller Quincke needle. The needle is inserted at L3 to 4 or below in adults and L4 to 5 in children. It is inserted in the midline at the superior aspect of the lower spinous process, with the bevel of the needle in the sagittal plane to prevent cutting of dural fibres. The needle is progressively passed through the ligamentous structures into the spinal canal. Sometimes a sudden give is felt as the needle tip pops through the dura and into the CSF space. The stylet is removed and the needle barrel is inspected for evidence of CSF release. If no fluid is flowing, the stylet is replaced and the needle is advanced a further 2 mm and the process is repeated. Once CSF is obtained, measure the opening pressure. This is performed by attaching the pressure manometer included in the pack. Collect CSF into the pressure manometer initially and wait until the level of the CSF has stopped rising in order to obtain a CSF opening pressure in centimetres of water. Temporarily stop the flow of CSF and record this opening pressure mentally. Collect your CSF samples by first evacuating the CSF present in the manometer, as this is the initial sample obtained from the patient. Collect the appropriate volume of CSF to the tests that you need to perform. The latter will be discussed further in a later video. If, on introduction of the spinal needle, you hit bone instead of ligamentous structures, then ensure the patient is properly positioned after withdrawing the needle back to the skin. Reorientate the needle, ensuring that you are in the midline, and advance once again in a slightly different plane. If nerve root pain is experienced by the patient on advancement of the needle, then you are most likely either to the left or the right of where you want to be. Again, stop advancing the needle, withdraw, ensure the patient is appropriately positioned, and advance again in a slightly different plane as required. Multiple dry taps will require a more experienced hand, or uncommonly may require image guidance. In this video, we have reviewed the basic anatomy of the lumbar spine and spinal cord, including the identification of Tuffler's line. We have outlined the preparation of the patient and equipment required, and described the insertion technique. In the next video, we will review the information that can be obtained from a CSF sample.